Well, thanks for inviting me, and thanks for having me and looking after me this week. It's been a wonderful week, and I've learnt a lot and enjoyed the food and the company. It's been really great. Yes, so I'm from Sydney and from St George Hospital, which is in the southern part of Sydney, around Botany Bay. And I work at the university as a clinical academic, but also have private rooms. I do a bit of research. I'm involved with our renal department, so I spread myself a bit too thinly. This talk's on hypertension. It's an area of interest of mine, particularly treatment-resistant hypertension, and we do a lot of hypertension at St George, and we also do a lot of pregnancy hypertension, which I'm not talking about today. That's for next time. Whoops. Okay, so basically that's an overview of my talk today. Hopefully you won't find it too boring, but I'll start, it's a general audience, so I'll start with general concepts and build along the way. And let's start with really what hypertension is. We still refer to hypertension as being a blood pressure above 140/90, and that's the clinic blood pressure. That correlates with 24-hour average blood pressure of 130/80, or indeed home readings of 135/85 while awake, though home blood pressure is not recommended for diagnosis of hypertension. I think home devices have become widespread. Everyone's got them, but no one's been trained in how to use them properly, and indeed the interpretation of those blood pressures in terms of clinical outcomes really requires a lot more research. So I think be very cautious about home blood pressure, and when patients use these devices, they really need to be trained in how to use them properly. The idea that high blood pressure is normal as you get older is false, and the reason for that is that there's always a correlation between blood pressure and cardiovascular disease. And these graphs show that no matter which age group you're in, as your blood pressure rises on the x-axis, your risk of stroke mortality also rises. And that relationship holds true whether you're young, say 40 to 49, or whether you're 80 to 89. So even in the older age group, there's this relationship that is abnormal. And that holds true. I'll just show you this one graph, but it's true for systolic hypertension, diastolic hypertension, and for both stroke mortality and coronary artery disease, ischemic heart disease mortality. With respect to blood pressure as a public health issue, it remains a major issue. 4.6 million Australian adults had hypertension in 2014, and it's estimated that 2/3 of those were uncontrolled. So just because you go to the doctor and get it treated, it doesn't mean it's controlled properly. It absorbs a lot of healthcare revenue expenditure. And you can see that the causes of death in Australia, top cause of death, coronary heart disease, and indeed dementia and Alzheimer's, which may well be circulatory as well in some cases, cerebrovascular disease third. So you can see that causes of death are largely vascular disease. I looked at the Department of Statistics Malaysia to see whether that relationship held true, and it's very similar. So these are the causes of death that have been certified in Malaysia. Ischemic heart disease 1, cerebrovascular disease 4, we've got transport accidents here and pneumonia. So males and females, pneumonia and ischemic heart disease second, so they're certainly up there. And that's by sex and that's by ethnicity. And again, 2014, 2013 data, ischemic heart disease regardless of the major ethnicities. So we talked about how hypertension is defined as a blood pressure of above 140/90, but in fact the Americans are trying to change the rules now, and their recent guidelines from 2018 have said that in fact hypertension is 130/80 or above. That hasn't quite been widely accepted yet. They may be right, but there's a lot of work to do before we label people as being hypertensive because of the implications of that label in terms of insurance, in terms of pharmacotherapy, in terms of cost, and in terms of benefit. We don't quite have the randomised controlled trials yet that have supported that change in definition. So, I just want to go through two other definitions. First being hypertensive urgency, which is where blood pressure rises and the patient is not symptomatic. It's not immediately life-threatening. But we see this a lot, patients turning up to hospital with a very high blood pressure that they may have recorded at home, or perhaps their doctor has recorded it. What do we do about that? A couple of studies recently have shown that admitting these patients to hospital is futile. A number of the guidelines around the world now are saying these patients should be managed with oral therapy and discharged, not admitted to hospital. Because really admission to hospital seems to be pretty much a waste of time. There was one study that showed that if you treat these patients in hospital, 6 months down the track they're exactly the same. So it probably wastes hospital days and doesn't do the patient any good. So that's really how we manage that asymptomatic type rise in blood pressure. Whereas when hypertension is associated with target organ damage, such as heart failure, pulmonary edema, visual disturbances, severe headache, and perhaps even renal disease, that's a different situation, and that patient requires parenteral therapy with careful intravenous therapy to lower blood pressure, often in the intensive care unit. I'll give you an example of a case of a young man that I saw recently. He's 42, untreated hypertension. He'd never really worried about it, never really seen his doctor. He went to his GP with headache. He was obese, he'd had a family. He thought that lifestyle management was enough for his blood pressure, which he'd been told about in the past. And his blood pressure was 255 on 155 when he saw him. His renal function was poor. His creatinine was at 499. Do we use micromoles per litre here or milligrams per decilitre? Micromoles. So he had pretty bad renal failure with a normal serum creatinine that should be below 110. And that increased to 700 over a couple of days. He had hypertensive retinopathy. He had left ventricular hypertrophy. And in fact, he was hemolyzing. And we did a kidney biopsy because of his renal failure. And this is a low power view that shows a lot of scarring. And you can see that these pink hyaline type lesions are old scarred glomeruli, and a lot of scarring of the tubulointerstitial region. And this is a typical appearance of changes in the arteriole with sort of onion skinning due to smooth muscle hypertrophy from long-standing hypertension and possibly even some fibrinoid necrosis. And that's the effect of this type of acute microangiopathic hemolysis due to hypertension with platelet fibrin thrombi in the glomerulus occluding them, causing the renal failure. Now sometimes this gets better with treatment, but in this man it didn't. And over time his kidney function just got worse and worse, and he's now on dialysis and has a donor hopefully lined up to give him a kidney transplant in the next few months. So it's a bad disease. These are the four categories of one's blood pressure. In the clinic you can have normal blood pressure or high blood pressure, and at home or by 24 hours it can be normal or high. So the best place to be from a cardiovascular perspective is here, where your blood pressure is normal in the clinic and normal at home. It can be high in the clinic and normal at home, in which case we call it white coat hypertension, which may be a benign phenomenon in a lot of people. It can be elevated at home and elevated in the clinic, sustained or uncontrolled hypertension. And then there's this new sort of category of blood pressure where the blood pressure is higher outside the office but actually normal inside the office, and that's called masked hypertension. And when we see that, we know that these people have increased cardiovascular risk, and we accept the home or the outside readings as being the true readings. Why this happens, no one really knows. So let's go on to management. For all patients, we always assess other vascular risk factors and lifestyle factors. So looking at physical activity, weight control, diet, smoking and alcohol intake. Each of these lifestyle factors have been shown from an evidence-based perspective to lower blood pressure when they're managed. We all know that it's hard for people to change their lifestyle, and sometimes it's very rewarding when someone does that, because most of the time people can't. It's hard to change physical activity, it's really hard to lose weight, smoking cessation and alcohol, so all very relevant in both of our sort of communities. But yeah, these are all evidence-based methods. We've got targets to achieve and resources in Australia that we can try and access. And then the next step is to look at associated cardiovascular conditions and risk factors. Sleep apnea is emerging as a major problem, and I suppose it's the same in Malaysia. Pretty much most people as they get older will have some degree of sleep apnea, it seems, and it seems to be a risk factor for a whole lot of bad cardiovascular outcomes in the future, including atrial fibrillation, dementia, hypertension. I understand that diabetes is a major problem here. I don't know what the rate of diabetes is here, but it wouldn't surprise me if it were as high as Australia's or higher. Hyperlipidemia. So when we treat hypertension in Australia, our guidelines recommend an approach based on the absolute cardiovascular risk. And we have a way of looking at that very, very easily using a cardiovascular risk calculator, which is on a website that's easily available through the Heart Foundation. And this risk calculator allows you to put in the sex, the age, systolic blood pressure, smoking, total cholesterol, HDL, diabetes, and any evidence of left ventricular hypertrophy. And you put that in and you come up with a score. I've used a 60-year-old male here with a systolic blood pressure of 122 and a risk of, I can't actually read that, I think it's 5%. So if I just go back, all patients with hypertension need to have lifestyle advice, as I showed you in that first table. If someone has low risk, then perhaps, depending on their blood pressure, you may or may not start antihypertensive therapy, but if their blood pressure is above 160/100, despite their low risk, antihypertensive therapy should be started. And then there's various sort of permutations of that, depending on their risk and depending on their blood pressure. I'll talk about this study from America a few years ago, 2015 I think it was, called the SPRINT study, that has sort of helped us define a target for some individuals of lowering blood pressure to less than 120 if it's tolerated. So that's a new sort of guideline that's come in the last few years as a result of that SPRINT study. So let's move to what drugs we use. Pretty much all the guidelines around the world will tell us that a blocker of the renin-angiotensin system, a diuretic, or a calcium channel blocker can all be used first line. As you know, some patients respond better to diuretics than perhaps blockade of ACEs or ARB. It should have a calcium channel blocker in up here. And in some patients, depending on the phenotype of the patient, whether they're diabetic, whether they have got cardiac disease, or whether there's end-stage kidney failure, or whether there's a history of stroke, you might choose to start one drug over the other. For example, some of the meta-analyses, and indeed some of the RCTs, have shown that calcium channel blockers are best for stroke prevention. So if someone's had a TIA in the past, you might want to be sure that they're on a calcium channel blocker. If someone perhaps has early features of mild kidney disease and they're diabetic, all the studies have used angiotensin receptor blockers rather than ACE inhibitors. So lots of evidence there. In terms of preventing myocardial infarction, ACE inhibitors better than beta blockers. And there was this study that showed that this combination of a RAS blocker and a calcium channel blocker is better than a RAS blocker and a thiazide. I think that was the accomplished study. And so that tends to be a favoured combination, although calcium channel blockers, of course, can cause side effects like peripheral edema. But overall, I suppose the take-home message is that there's no major differences in cardiovascular mortality when you look at the three major classes of antihypertensive first-line drugs. Happy to take any questions, by the way, during the talk if you want.
Your ACE inhibitor, how careful will you be monitoring the renal function when you start something like that?
Yeah, so the question is, if you're starting an ACE inhibitor or an angiotensin receptor blocker, how carefully do you monitor renal function after you commence the drug? When we first started using these drugs, there was always a warning about checking the potassium and checking the renal function within a few weeks. I think if they've got normal kidney function with normal GFR above 90 and no other drugs that are potassium sparing, I don't think you really have to worry too much about that. It's unusual for that to cause acute kidney injury in that situation in an otherwise healthy patient. It's the ones where they've got perhaps reduced GFR, perhaps mild CKD with a GFR that might be 60 or 50, and perhaps they're on other medication where there's a really real risk of causing life-threatening hyperkalemia or acute kidney injury. And in that circumstance, those patients might have diffuse vascular disease and perhaps renal vascular disease, what we might refer to as bilateral renal artery stenosis, if you like, but perhaps not, maybe even microvascular disease in the kidneys that it makes them more sensitive. So in those patients, you start with lower doses, yeah, and check within. So that's a very good question. Is there a cutoff where you don't use an ACE inhibitor or an angiotensin receptor blocker in terms of renal function? I've seen studies where they've started these drugs in patients with a GFR in the range of stage 4, where the GFR is between 15 and 29 mils per minute, and it still showed benefit, cardiovascular benefit. So there really isn't. We like to use these drugs in our patients who are on dialysis because we know they've got widespread vascular benefit. There are multiple studies showing that. The problem for us with looking after patients with kidney failure is that their vascular disease is different to the vascular disease of patients with normal kidney function. They get a different type of vascular disease, and the ACE inhibitors may not work so well. But still, we try to use them, and I think that these two classes of drugs, ACE inhibitors and angiotensin receptor blockers, are really the only drugs that will control blood pressure in some situations, and you really have to have people on these drugs. And I have to also say that I often get students and doctors telling me that they're nephrotoxic and bad drugs. Well, they're not. They're the opposite. They're really the only class of drugs that have been shown to be renoprotective. And when you look at survival data in treatment-resistant hypertension, they not only save lives, but they save kidney function, much better than perhaps the older-fashioned drugs. So even though people think, I can't start an ACE inhibitor because they've got renal disease, you should be thinking the opposite way around. They've got renal disease, so I need to start an ACE inhibitor to protect the kidneys and to get blood pressure under better control. So I have to unteach that, and it takes a long time to do that. So we've got our drugs, we've got our lifestyle management, we've assessed cardiovascular risk. How low do we lower blood pressure? The earliest studies that were in the 1960s told us that if you had malignant hypertension and you gave a drug like hydralazine, you bring the blood pressure down and people didn't die of heart failure anymore. So that was the early VA study. Then subsequent studies over the years have allowed us to define what hypertension is. And then there have been a few studies that have tried to look at lowering blood pressure to a certain target. We know that lowering blood pressure is good, but we didn't know that what the target was. This study in 1995, the HOT study, looked at people with hypertension and divided them into 3 groups. There are about 6,000 patients in each group, aiming to lower blood pressure to a diastolic of 90, 85 or 80. And what happened was that there was a failure for the 3 groups to separate. that the drugs all lowered the blood pressure and they're all similar. So we didn't see the separation of the blood pressure, and we didn't see a difference in cardiovascular outcome. However, from that study, post hoc analysis showed that the best cardiovascular outcomes were at around 139/83. And then subsequent studies have failed to show benefit. The Accord study, I'd like to talk about the Accord study in 2010 and the Sprint study in 2015. The Accord study looked at, it was a 2x2 randomised controlled trial looking at intensive versus standard glycemic control in diabetics, plus or minus tight versus relaxed blood pressure control, or statins plus or minus fibrates. So it had a number of randomisations within the groups. In the sub-study, there were 10,000 patients in this study, but there were 4,700 that looked at blood pressure control, less than 120 versus less than 140. And they used a composite cardiovascular endpoint to look at outcome. And that was the 2x2 factorial design. So there was, all patients had either intensive or standard, and then you could have one of these subgroups. And what they did in this study, they were able to achieve a difference in systolic blood pressure over the years. So from a technical perspective, the study worked. However, the primary outcome, really, there was no difference. And that's a bit disappointing. So it suggested, we thought that with diabetics, their vascular system would be more sensitive, and that perhaps you lower blood pressure further, they have benefit. The Accord study failed to show that. Actually, it also failed to show any benefit of more intensive glycemic lowering or adding a fibrate. So it was a negative study across those three sub-studies. But then this study came along in 2015, the Sprint study, and these were not diabetic patients, but they had patients with increased cardiovascular risk. And it was specifically designed with a primary outcome of either a blood pressure below 140 or a blood pressure below 120. And you notice that they used systolic blood pressure. In the observational studies from the old Mr. Fit cohort, systolic blood pressure remains a more closely related risk factor for cardiovascular disease than diastolic. Both are important, but systolic is more important and often more difficult to control. Some of these patients had CKD and some of them had already had cardiovascular disease. So 9,000 patients. And this is, looks like an identical graph to what I showed you before from the Accord study. This is the separation of blood pressure over the 5 years. So you see standard treatment, blood pressure was just below 140, and intensive treatment, blood pressure around the 120 mark. It's hard to achieve this in reality, in practice. As you know, patients get dizzy, they have side effects, they need a lot of drugs, they don't like to take them, they're non-compliant, etc. And this study was terminated early by the Data Safety Monitoring Committee because of a separation in the outcomes between the two groups, where the intensive treatment had a lower incidence of, a lower hazard ratio of the primary combined cardiovascular outcome and death from any cause. So a very impressive and positive study that we're still trying to deal with, trying to work out the ramifications of it. In other words, lowering blood pressure below 120 is better. And that's the question that this study asks. Should it be driving blood pressure targets down? So to answer that question, we need to look at the study more carefully. Is it a study that's generalisable? Well, these were all high-risk patients. Now, many of our patients are not in that high-risk category. They're lower risk. They may only have hypertension. They may be younger and otherwise be well. So that's the first point. Secondly, it's difficult for many long-term patients to sustain that, and that may be due to symptom control and adverse drug reactions and tolerability of the drugs. And side effects. A lot of these drugs cause side effects. Indeed, adverse events were higher in the intensive group, 4.7 versus 2.5%. So almost double the number of patients had side effects. the reduction in blood pressure in the SPRINT study was only 18 millimetres of mercury. So what that means is that some of these patients may have started with a blood pressure of 141 systolic and come down, whereas a lot of our patients may start with a blood pressure of 160 and bringing their pressure down to 120. That's not the same as what we've seen in the SPRINT study and may require a lot more medication. And finally, SPRINT used this different method of blood pressure measurement, not the clinic measurement that we've been doing in the OSCEs, but using an automated device where the patient sits in a room with the door closed, no clinician in there, and the device measures the blood pressure 3 times and averages it. That's very different to what a clinic blood pressure is, where there could be a white coat effect of 16 or 18 or 20 millimetres of mercury when you're with the doctor. So a whole lot of parameters that make the SPRINT study not necessarily generalisable to the broader population. So this is from our Heart Foundation, and this is the current blood pressure targets that. So we haven't adopted the SPRINT outcomes fully yet, and we certainly haven't changed our blood pressure definition based on the based on the American Heart Association guidelines from this year. But basically, general target for blood pressure less than 140/90 or lower if tolerated. That comes from SPRINT. Depending on cardiovascular risk, less than 140/90. Secondary prevention of coronary heart disease. So for some subgroups, less than 130/80. And that's online. That's on the Heart Foundation website if anyone's after it. And that leads me to the next part of the talk, which is about treatment-resistant hypertension, which is a major issue. So when we look at blood pressure control, we think that a lot of our patients take their tablets and have good blood pressure control, but that's not the case. It's defined, this definition of treatment resistance is defined as a failure to reach an office blood pressure of less than 140/90. But to be part of that, you need to be on 3 or more agents, including a diuretic, and most of the guidelines say the same thing. We need to have some understanding that patients are taking their medication and that the dosing used is the maximum tolerated. Then we can define them as treatment resistant. This whole area is evolving. An author in the States has sort of subdivided this, where he's done a whole lot of hypertension clinics and talked about controlled, resistant or refractory hypertension. And this particular subgroup of refractory hypertension, he calls this group patients who are on 4 or more antihypertensive drugs, who remain hypertensive and who've had all the screening tests and who've had ambulatory blood pressure monitoring to exclude a white coat effect. It's important to think about whether patients have a white coat effect in this situation. So I'll just show you one study from Spain where 8,000 patients had resistant hypertension in the office, fulfilling those criteria. And they underwent 24-hour ambulatory evaluation to determine whether they had controlled hypertension outside the office and whether it was a white coat thing or whether they were truly resistant. In fact, a third of them had controlled hypertension. So of this 8,000 patients, or for example, of your patients in the clinic, perhaps a third of them are actually controlled. And those patients where you've escalated the drug therapy and where blood pressure remains elevated, it's important to use ambulatory monitoring or perhaps home blood pressure monitoring to sort this out. I would not recommend home blood pressure monitoring to sort this out. I would be suggesting ambulatory monitoring because it takes away the interaction between the human and the machine. It's on the patient for 24 hours. They walk around, they do their own thing. They don't see what the numbers are like, and they take it back the next day to the clinic and have it removed and the data is analysed. So that will tell us that about a third are actually controlled, because you don't want to be escalating medication here, because all you'll do is cause more side effects. And this is the group that you want to focus on. Why do patients become resistant to treatment? What are the causes? So we've talked about the white coat effect, and we've talked a lot about non-adherence. I've just been to a meeting where we talked about treatment-resistant hypertension, and some of the recent studies are showing that perhaps 60% of treatment resistance is due to non-adherence. When you do urinary drug assays and blood drug assays, and you find that patients actually aren't taking their drugs, even though they say they do. So that's a very challenging issue to have to deal with when your patients are telling you what they're doing, but they're not. You know, it's sort of very hard for a clinician to come to terms with that. You sort of get a bit offended, and we all have to learn with ways to deal with that. What about other conditions? Obesity, drugs, alcohol, salt, licorice, all the stuff that we love, sedentary lifestyle, and of course sleep apnea. So these things can be managed. Inadequate treatment perhaps, so dosing may not be correct. There's this concept of hidden sodium in water, and I talked before about the importance of making sure a patient's on a diuretic, thiazide diuretic. Often if patients aren't on a diuretic and they're treatment resistant, you put them on a diuretic and their blood pressure comes down. So some of these patients will have essentially, you know, they may be liberal in their sodium intake, or they may not excrete it, or perhaps they may have a little edema as they get older. And when you treat that sodium and water overload, their blood pressure comes down. And when you see a patient who has treatment-resistant hypertension and edema, then you have to think about that possibility of sodium and water excess and treating that appropriately. So that relates to their dietary sodium intake as well. Failure to use a diuretic, so I've talked about all that. And in the patients where they're really refractory to treatment, from that American group that I talked about before, some of those refractory patients had evidence of sympathetic nervous system overactivity. We can't measure this in clinical practice. To measure the activity of the sympathetic nervous system in clinical practice is very, very difficult. There's no easy test. There are research methods such as noradrenaline spillover, and there's invasive testing, but unfortunately we don't have an easy test to do that. If we did, it would be great, because we've got drugs that block the sympathetic nervous system. We don't like to use them because they cause side effects. But if we knew who had this, we'd be able to target therapy better. And finally, there's these secondary causes that I've put down the bottom that we teach our students. Aldosteronism, so Conn syndrome, renal disease, renal artery stenosis, and pheochromocytoma. And notice I haven't put Cushing's syndrome in here, because Cushing's does cause hypertension, but it's so rare that you know, it's not a common cause of hypertension that we see day to day. I suppose pheochromocytoma is rarer than Cushing's. That's a pheo from a young girl that was pregnant, and that's a renal artery stenosis. So just some considerations in patients who have treatment resistance. So think about volume control and using diuretics, thiazide diuretic like hydrochlorothiazide, or chlorthalidone that's probably a bit more powerful, or a loop diuretic if they've got reduced GFR, because the thiazides won't work so effectively in that situation. If a patient's tachycardic, then you might want to use a drug that slows the heart rate, because that will contribute to blood pressure. If the patient has a suppressed renin and aldosterone system, in the absence of drugs that will be causing that, you might consider the use of a drug that blocks aldosterone, the AT1 receptor. So you could use an AT1 receptor block, or you could use spironolactone or eplerenone. And these drugs that block aldosterone are becoming increasingly important. I'm going to talk about those in a moment. So split dosing of medications. With 24-hour monitoring, sometimes you see that the patient's blood pressure profile behaves in a way that suggests they need medication at a certain time of day, or that perhaps if they take all their medication in the morning and you see a sudden dip in their blood pressure, adjusting or splitting the dosing may help improve blood pressure control and lower the blood pressure loads. Adherence is always going to be difficult, and there's a number of ways that can be done that can be looked at. Looking at blood pressure at home is useful, but again, not using the home device to diagnose hypertension rather than to monitor the blood pressure. And of course, if the patient's got sleep disordered breathing or anxiety, or those sorts of things, can be managed separately. So the list the bottom of that list I just showed you were the secondary causes of hypertension. Aldosteronism used to be thought to contribute to about 1 in 200 cases. It's now thought to be around 15 in 100 cases, 15% of hypertensives, perhaps more, depending on the centre. It's a difficult and frustrating disease to investigate and diagnose because the tests we do are not black and white, they require interpretation, and the drugs we use affect the tests, so we have to take patients off the drugs that affect the results. Then we have to do this very carefully. Firstly, determine whether they've got an elevated aldosterone to renin ratio as a screening test, and then perform some form of suppression testing to see whether the aldosterone suppresses appropriately, and if it doesn't suppress, then you've made a diagnosis of primary aldosteronism. And then you can do adrenal vein sampling to see whether they've got a unilateral or a bilateral disease. In most patients it's bilateral, so it's not common for a patient to proceed to an adrenalectomy, and in many cases I use spironolactone in these patients, which usually provides good blood pressure control. So renal parenchymal disease is another secondary cause, easily diagnosed with a urine test, a GFR and imaging. Pheochromocytoma is rare, and we don't do 24-hour urines anymore. We haven't done them for 15 years. We now use fasting plasma metanephrine testing, which is a lot easier and doesn't require a messy 24-hour urine, and highly sensitive. Subject to false positives, but highly sensitive, which is exactly what we want for a rare disease. And finally, renal artery stenosis. So that's another disease that's disappointing, and most of the screening tests are unreliable apart from an angiogram, a digital subtraction angiogram. Probably the next best non-invasive test is a CT renal angiogram. I'll just show you, this is a pattern that you've seen before. That's fibromuscular hyperplasia or fibromuscular dysplasia, common in females. It's a common cause of hypertension in a young, thin female, and it may be missed when you try to do an ultrasound Doppler. Ultrasound screening for these renal arteries is generally disappointing and a bit unreliable. So you probably have to do a CT or proceed to an angiogram if you're really looking for it. The good thing about this disease is that it responds to treatment. So about an 80% response rate to angioplasty. The problem with it is that it also occurs in the carotids and the cerebral circulation. So if you find it in the kidneys, you may find it up here, and whether you're screened for that or not is a little bit debatable. And I won't talk about that today. That's for another talk. This, on the other hand, is a disappointing cause of renal artery stenosis. That's atherosclerotic renal artery stenosis, where you've got a proximal stenosis at the ostium and a bit of post-stenotic dilatation, as compared with fibromuscular disease, where the stenoses are often more distal and often missed on an ultrasound, and there's often multiple webs and little sort of aneurysms. So this disease was widely treated in the 1990s. That's the number of stents that were put in, I think it was in the States, from 1996 to 2005. 35,000, and it grew wildly, and that was despite the fact that the study showed no benefit. We didn't really have proper RCTs. Stuck. We didn't really have proper RCTs until there were 2 large studies published about 10 years ago. The first being the Astral study, where patients were randomised to either a stent or sham, 806 patients. And this study was the first to really show properly that when you dilate a renal artery that had atherosclerotic disease, You had no effect on kidney function over time compared with medical therapy, no effect on reciprocal of serum creatinine, so no effect on GFR, and no effect on blood pressure compared with medical therapy. So an older patient, atherosclerotic renal artery stenosis, we don't treat them anymore. This was the other study that showed the same thing that was published a little later, 2014, called the CORAL study. About 1,000 patients assigned to stenting or medical therapy. Same thing, no benefit. So really, the only place for renal artery stenting and angioplasty is with the younger patient who has got fibromuscular disease. And for that reason, we don't look for this disease anymore. We don't screen for it in older patients unless they're starting to get pulmonary edema or rapidly deteriorating renal function, where those patients really weren't included in the studies and may benefit still from angioplasty and stenting. So we only do it in the patients who really earn it, and we've shown a stenosis in a kidney beyond the stenosis that looks reasonable. There's not much point in stenting an artery if the kidney is shrunken and ischemic and not performing. So yeah, we only screen now for fibromuscular hyperplasia in younger patients, or possibly these refractory sort of bad older patients who are getting sick, who may not have been represented in the RCTs. And I'd just like to talk about spironolactone because it's becoming increasingly important. It's a drug that it blocks the mineralocorticoid receptor along with eplerenone, and in a number of studies it's been shown to be beneficial in patients who are already on a number of drugs. This was a study that compared two treatments, CCB and ACE inhibitors versus beta blockers and thiazides, 20,000 patients, and spironolactone was added in as a fourth-line agent. And in this study, the patients that received the spironolactone had a major reduction in systolic and diastolic blood pressure, with the cost being some side effect rate of breast enlargement, breast discomfort, sometimes breast nodules, and hyperkalemia. There was another study where a number of drugs were added on to patients who had resistant hypertension. And in this study, you add on a placebo, so the baseline blood pressure is here, add on a placebo is here, and these are the three drugs that were added on, and spironolactone again was the most effective. And generally when we use spironolactone, we don't need to use the old-fashioned doses of 100, 200 milligrams. We can now use 12.5 to 25 milligrams, which has the therapeutic effect without the androgenic effect. Anti-androgenic effect. So the higher doses seem to cause the breast problems and other anti-androgenic effects. And just towards the end of my talk now, spironolactone has been compared with a procedure called renal sympathetic denervation, and I'll talk about that in a moment. It was only a tiny study with 24 patients. So in that study, spironolactone was more effective than denervation. So it's a good drug, and it's now recognised generally as a fourth-line drug for those patients with treatment resistance. It has to be used with caution because you're using it with other potassium-sparing agents like RAS blockers. And if patients have got reduced kidney function, it's a good idea to use the spironolactone and reduce or stop the ACE or ARB therapy. The cost is that it causes breast tenderness, about 10% of that in males, breast lumps, hyperkalemia, hyponatremia, and a whole lot of other side effects. In Australia, we can't get this drug for hypertension. We can get spironolactone easily enough, but it has all these side effects. The new version of it, eplerenone, is indicated for myocardial infarction. We don't have an indication for hypertension, so it would cost a lot to prescribe it. But the alternative is this old-fashioned drug called amiloride or calural, which is a nice little drug that, instead of blocking the mineralocorticoid receptor, it blocks the channel in the renal renal tubule called ENaC, and it essentially blocks the channel where sodium reabsorption occurs. So it does the same thing as spironolactone. It's not quite as effective, but it's a useful drug and it's very cheap. just so that you know, that's aldosterone, so it's a 4-ring steroid. That's spironolactone, so it looks like aldosterone, and that's why it blocks it. That's licorice, and that's cortisol. So they all look pretty similar, but have very different effects. So what about renal denervation? Does everyone know what renal denervation, or does anyone not know? So this treatment came along called renal denervation about 10 years ago. And I've just got this picture of a pharmacy that I saw. We don't have Lyme disease in Australia, but apparently we do. So there's this conflict in Australia of whether we've got Lyme disease or not, and there's a whole lot of people who have something that they think, and some of them think it's Lyme disease, and they go and get these expensive treatments, and now there's pharmacies that look like that. Anyway, and I put that up because we've got this treatment called renal denervation. It was developed by a small company in California and then purchased by Medtronic. And this is where I'll declare a conflict of interest, because I've recently been to a Medtronic meeting and they've given me an honorarium for that. So this treatment, the technology was purchased by Medtronic about a decade ago, and I think it cost them $1 billion, because some early studies showed that if you treated a hypertensive patient with this device, which is a radio frequency electrode, and treated the renal artery by burning, doing some burns around the renal artery, you could destroy the renal nerves. And the nerves that travel to and from the kidney are both efferent and afferent autonomic nerves, both sympathetic and parasympathetic fibres. And it's thought that if you destroy the sympathetic fibres, you lower blood pressure. The pig studies were very striking, blood pressure reductions of about 30 millimetres of mercury. The early human studies were very striking. So the studies that weren't randomised were very striking, with blood pressure reductions of like 25 to 30 millimetres of mercury. The first RCT was called the Simplicity Hypertension 2 study, and showed a significantly better blood pressure reduction in patients who had renal denervation. So I learnt this technique. We performed some at St George. We've contributed to the international registry, and we've stopped doing it. We've stopped performing this procedure because this study came along. This was the larger, proper randomised controlled study called the Hypertension 3 study, and it was sham controlled. So patients either were treated with denervation, patients with treatment-resistant hypertension either had denervation or a sham treatment. 500 patients, and it was done in America. And this really threw a spanner in the works for this company, because it showed that the denervation was no better than the control treatment. So that essentially led to a whole lot of centres around the world no longer doing this procedure. You've got an RCT that is performed by investigators that were well known, and the safety of the procedure was fine, but it didn't work. Interestingly, there was a large drop in blood pressure in the control group. So essentially, denervation stopped, and the company has now done a few more smaller RCTs, and they've worked out that the Hypertension 3 study may have had flaws in it for a whole lot of reasons. They've done a couple of smaller RCTs, and they're now showing that it's probably more likely that this procedure does work, but only lowers blood pressure by about 10 or 13 millimetres of mercury. And I think what this company is doing now is trying to find a place for this device in the treatment of hypertension. But the larger studies are underway, and we really have to wait for the data. So certainly we can't use this treatment in treatment-resistant hypertension yet. There have been other devices used for hypertension treatment, including carotid baroreceptor stimulation. So continuous electrical stimulation of this baroreceptor has been shown to lower blood pressure. Unfortunately, it's dangerous and causes a whole lot of, can cause nerve palsies and things, so that's not in clinical practice yet. And there's been nothing else that's evidence-based yet. So I think, and there is a number of antihypertensive drugs that are in the pipeline as well. The trouble with some of these drugs that are combined, they cause a lot of side effects, and we see this with the new cardiac drugs that have neprilysin inhibition that can cause a whole lot of side effects when they're used in very fragile older patients. So I suppose that the take-home message is that we're stuck with drugs at this stage. Lifestyle change is indicated for all patients with hypertension. When we prescribe, we should think about absolute cardiovascular risk, and that would drive our decision making, particularly with respect to how far we lower blood pressure. In terms of secondary causes, fibromuscular hyperplasia, that type of renal artery stenosis that occurs in young women, is treatable. But atherosclerotic disease should not be screened for in stable patients and should not be treated. So there's no point in really looking for it. Spironolactone turns out to be a useful add-on drug, and procedures to lower blood pressure at this stage don't work. So I'm going to stop there, and happy to answer any questions.
Your previous slide, just the one before, yeah. We use a lot of spironolactone as a gastroenterologist now. I use like 300, 400 milligrams a day for
Ascites, yeah.
But we don't see the blood pressure coming down. I mean,
But those, yeah, the question was about,
only about 25 milligrams, isn't it?
yeah. So,
And is it in combination that you see the hypertensive effect?
yeah. The question was about the use of spironolactone in gastroenterology practice, where it's used in high doses for the treatment of ascites in chronic liver disease and portal hypertension, and why you need such high doses in that situation, I've never really been clear about. They already have gynecomastia and anti-androgenic sort of feminisation within this situation, so it's hard to see the side effects. And the question was about why we don't see blood pressure lowering. I suspect in the cirrhotic circulation you often have lower blood pressure anyway. It's not unusual to have a hypertensive patient who eventually gets cirrhosis, whose blood pressure comes down with that sort of vasodilated splanchnic sort of situation. And so maybe there's no further antihypertensive effect of spironolactone. But on the other hand, it's not unusual for these patients to get into trouble with acute tubular necrosis at times when their cardiovascular system collapses due to bad cirrhosis and other comorbidities, and you know, when they get SBP or whatever, they really fall apart. So maybe you do see, it's just that we don't really look for it carefully in those patients.
Just wondering what are the common renal parenchymal diseases that you encounter that cause hypertension?
So the question was, what are the common renal diseases causing hypertension? Really any of them, but any form of reduced GFR will cause hypertension. Almost all patients with you know, end-stage renal failure are hypertensive. The common causes of reduced early kidney disease around the world, the commonest is diabetes now, any form of glomerulonephritis. And the ones that don't cause hypertension are those genetic, those inherited forms where you've got sodium wasting nephropathies like Barter's syndrome. So, but the acquired forms of kidney disease, yeah, all cause hypertension.
Do you have a lot of lupus nephritis and HIV?
In Australia, we don't have a lot of HIV nephritis, no, and in Australia we see some lupus, but nowhere near as much as what I'm sure you see here.
Would you like to comment on treating hypertension in the elderly, in those in the 80s?
So the question was about treating, a comment about treating hypertension in the elderly.
They seem to be more susceptible to side effects,
Yeah.
especially when you bring down the blood pressure.
Yeah, I think the comment you just made about side effects is very, very relevant and important in terms of side effects to treatment. There's really no evidence when you're 85 or over that lowering blood pressure below 160 is of any benefit. So in that older patient group, I think it's time to look at their medications that they're on and perhaps reduce. It's very hard for us as doctors to do that. The geriatricians do it well, to pull back on medication, say you probably don't need that, because eventually that patient will fall over, break their hip, and that's it. So I think a higher target for those who are 85 and older. For those who are sort of in that 75 to 85 group, think very carefully about drugs that are going to cause side effects. I try not to use alpha blockers in those patients because of the postural hypotension, so prazosin I try to avoid, and variations on that. Older patients have stiffer arteries and therefore they'll respond to diuretics better. So I like to make sure that they're on a diuretic as a sort of foundation of their treatment, although again they'll be more susceptible to hyponatremia. And generally lower doses, not sort of higher doses of a single drug, sometimes lower doses of 2 or 3 drugs. Calcium channel blockers are useful in that subgroup as well because they're at high risk of stroke. And so, as I said earlier, calcium channel blockers are good for stroke.
Target would be different from younger age.
Only in the 85 years and older. I think in anyone below that, your target is still around that below 140 over 90, but I think it's natural if you've got an older patient who's already on who's already got polypharmacy, and to reassure yourself that if you've lowered blood pressure from 160 to 140, that 20 millimetre lowering has halved their cardiovascular risk. So the benefit of lowering it from 140 to 120 might be another halving of their cardiovascular risk, but the cost might be a fall, a side effect, and death. So I think it's a balance between how far you've brought the blood pressure down and how much medication they're on, and what the marginal benefit is of further therapy. In the younger patient, I think you can be a bit more aggressive, yeah. But it does come back to bite you. If you put them on too much stuff and they're fine, 4 months down the track, they'll come back with a bit of gastro and get acute kidney injury or the flu or pneumonia. Yeah.
What's the maximum number of drugs you put for someone that?
So what's the maximum number of drugs we can use for? So for some patients that we just can't control, sometimes they're on 6 or 7 drugs, and there's a bit of futility there, but that's where we were looking for a treatment like renal denervation to be effective, and we did 12 cases at St George and we saw a small benefit when we looked at our data over using 24-hour monitoring over 2 or 3 years of about 12 millimetres of mercury, which is similar to what those new studies are showing. But yeah, there's a point where it's futile and it's just going to cause side effects. So that asking that question to yourself, if I do this, if I give this treatment, what's the marginal benefit? Is it that much or is it that much benefit? And what's the risk? And it's a point where the risk becomes, side effects are going to be far more than the benefit, not worth it. All right. Well, thank you very much. Thanks for staying awake.